Warning: suicide and death. This content addresses mental health issues, including research and narratives on suicide. Please take care while engaging with it and only proceed if you feel safe doing so. If you or someone you love is having thoughts of suicide, please contact 988. Help is available. Welcome, everyone. I'm your host, Lisa Meeks, and you're listening to the second episode of our series on medical training and suicide. If you haven't already listened to the first episode, I strongly encourage you to do so, as it provides important context for our discussion today. In our first episode, we introduced Dr. Jack Ruddell, a medical student who died of suicide shortly before graduating from medical school. His story is the foundation of this series. In today's episode, we will discuss the statistics surrounding suicide, particularly within medical training and practice. We'll also explore the factors that contribute to this devastating reality. This series is produced in collaboration with John and Jennifer Ruddell, with the aim of sparking meaningful conversations and promoting policies and practices within medical education that encourage help-seeking behaviors and address the challenges compromising the well-being of medical trainees. We dedicate this episode to the memory of Dr. Jack Ruddell and all of the medical trainees we've lost to suicide. We begin today's episode with an introduction from our consulting psychiatrist and narrator, Dr. Joseph Murray.
Welcome back to the podcast. I'm Joe Murray, a psychiatrist at Weill Cornell Medical College and a consultant for this series. Before we begin, I want to acknowledge that today's episode covers sensitive topics, including suicidality and suicide. The content and research discussed may be distressing to some listeners, so please proceed with caution. If at any point you feel overwhelmed, it's okay to pause and return later. If you're struggling with your mental health or experiencing suicidal thoughts, know that help is available. You can call or text 988 to connect with the 988 Suicide and Crisis Lifeline, where trained professionals are ready to support you. Remember, it's okay to reach out. You are not alone. In today's episode, we'll start with a review of suicide statistics and why they might present in medical training by Dr. Christine Moutier, a leading expert in suicide prevention and the Chief Medical Officer at the AFSP, the American Foundation for Suicide Prevention.
$1.6 million adults will have a serious suicide attempt in a year, and we lose approximately 50,000 to suicide. Unfortunately, suicide is a complex health outcome, and so there is no community that is immune from it. And certainly for medical students and trainees, and also physicians and other health professionals in their careers, there are absolutely risk factors that are germane to just being human and having things like early childhood and genetic loading and mental health predispositions, but then the environment that can be not only a pressure cooker, but where help seeking and linking up with treatment has had some barriers in the past. Those are the reasons that, unfortunately, we do see suicides occurring in our own community of health professionals and physicians and trainees. Hundreds, thousands of medical people, trainees and otherwise, are in therapy, are getting treatment for depression or anxiety or PTSD or any number of things, just like you would for hypertension or other physical health problems. And I've always seen how that protects and helps those individuals who do connect to the treatment that they need, really protects them from not only their own health consequences, but those things that they fear in terms of career problems. So what we know from the suicide research literature is that mental health problems are extremely common amongst suicide decedents. Now, that doesn't mean that every one of those individuals who dies by suicide and had a diagnosable mental health condition was seeking treatment or was aware that they had a diagnosable and potentially treatable condition. We really see how mental health plays a very, very potent and powerful role in a path to suicide, but it is not the only risk factor. And it's also complicated by the fact that, thankfully, the vast majority of people with major depressive disorder, with anxiety disorders, with bipolar disorder do not die by suicide. I don't want anyone to think that because you have been diagnosed with depression or anxiety, that this is somehow kind of fate, that your path will lean towards suicide. That is not the case. And the better that we take care of our mental health, the more we protect ourselves.
Earlier in her career, Dr. Moutier served as dean at the University of California, San Diego School of Medicine. Having personally experienced the pressures of medical training and the associated depression, she recognized the urgent need to become an agent of change. Driven by this awareness, she focused on reducing stigma and breaking down the barriers to seeking help. In the following section, she discusses how she approached these challenges in her leadership role.
The complexity comes around the fact that there are many other risk factors. Like most things where change is needed, it's a process, and it's usually a multi-pronged approach over time. What we did at UCSD when I was there, the first thing was to take a look at all of our policies and look at them through the lens of, is there some type of stigma or extra barrier that was unintentionally created around seeking help for mental health? Because sometimes these policies have been sitting there for years or even decades without getting a good review. And in fact, we found a couple of policies that needed to be changed. For example, there was a policy that prohibited students from taking a leave of absence until they had failed a course. And that was based on an assumption that students would abuse leaves of absence and feign health or mental health experiences. And of course, we know the opposite is true, and that it's a grave problem for physicians and for health systems that there are unaddressed mental health needs going on within learners and physicians. So that was an easy one to change, that students could take leaves of absence by meeting with the dean and just discussing what was going on. And so that's step one, is looking at policies. Step two is explaining and educating students. You have to do it over and over again about how things work in this environment, that you will not be penalized for seeking help. In fact, you're going to get our support. The experience of mental health distress is very, very common. And generally, the way that it hurts students is that they're so busy trying to just deal with it on their own without professional help, support, or treatment. They don't have the energy and the clarity of mind to focus on their studies and patient care in a way that allows them to learn and grow optimally. So I think the education piece is huge. And again, it needs to be done over and over in a variety of different ways. And the messenger can be the top leadership as well as others within the med school environment, so that they're hearing it from all sides. I think you just need to assume that students will come in with a lot of fear around these issues, if not in their own life, with an assumption that the school is kind of entrenched in those old-fashioned ways that were actually highly stigmatized around mental health.
Dr. Srijan Sen is the Francis and Kenneth Eisenberg Professor of Depression and Neurosciences at the University of Michigan and the director of the Francis and Kenneth Eisenberg and Family Depression Center. He has devoted his career to leading the Intern Health Study. This groundbreaking research focuses on understanding how stress during the first year of post-medical school training leads to depression using genomics, mobile technology, and other innovative tools. Dr. Sen, like many in the field, was driven to this work by his own deeply personal experiences. In the following segment, Dr. Sen discusses the motivations behind his research and its relevance to studying suicidality in medical trainees.
I became interested in physicians and training physicians in particular as I was going through the process of training to become a physician, and really noticed that the people I was around and myself and others were generally doing well before we started. And then after going through or while going through this stressful experience, developed a lot of symptoms and problems that are consistent with depression, anxiety, and some of the more extreme cases, suicidality. And so I'm interested in understanding physicians and training physicians as they go through the experience to help them, and also hopefully using them as a model where we can follow people as they encounter stress to understand depression, suicide, and other problems that are related to stress in the broader population. I think a lot of us have stories. For me, while I was in medical school, one of my close friends who was also in medical school and moved on to residency, we were very close and talked about our struggles and stresses in medical school, and also much more broadly about philosophy in the world. And he began to struggle during residency for a variety of reasons, but the experience was certainly part of it. And tragically, and this is still one of the days in my life I most remember, he took his own life. And that I think about that and him often, and that a real driving force behind my interest in this topic and trying to make changes that can help reduce the tragedy of suicide. I met some of his residency colleagues and other people within the medical school and had a familiar and common response of why he would take his own life, what was driving it, what this means for other people who are feeling down and who else might be at risk, and what we could have done individually as a group, as a school to have changed it. Were all questions that people were asking. And in my experience with other residency programs and medical schools who suffer this kind of loss, that's a frequent set of questions that often come up and have perfect answers that certainly close friends, family, and then schools are grappling with.
Dr. Sen continues by discussing his work on the intern health study, which focuses on first-year residents, a population he identifies as uniquely vulnerable.
There's stresses throughout training to be a physician and other experiences. It is a highly stressful year. And as we've found in others, that the individual stresses and the rates of depression, suicidality, anxiety are higher during that year than any other year in training. It's also a relatively unusual situation, both in medicine and more broadly, where we can predict that stress is going to occur. So we can start following people when they're in a low stress period, and then follow them as they start working long hours, dealing with life and death situations, and a number of other stresses, and really follow in a fine-grained way how people react to the stress and as they develop the symptoms that are all too common during intern year. Transitions in general are a time of mental health problems, and changes in capturing those transitions and how people react are important. Rates of mental health problems are really high during medical school as well. Especially during the pandemic, the rates of depression and suicidal thoughts have gone up. There's drivers some that are common with what we know about the drivers of suicide and suicide attempts and suicidal ideation. The general population, men die by suicide more often than women in the general population and have higher suicidal ideation. Certain personality traits, most notably neuroticism, is associated with suicide risk in the population. And in our sample, as I mentioned, people with depression, anxiety have higher rates of depression. Again, what we were able to do in our sample that's relatively unusual is we were able to look at people before they developed these symptoms and suicidality and find predictors. And we found all those factors were important. There are also some factors that were specific to medicine, probably most notably work hours. And we finding that to be a real driver of stress and mental health problems across the board. Work hours were a driver of suicidal ideation here, and particularly an increase in work hours from one period to the next being a major risk period that maybe would be worth flagging, and people with major increases in work hours to be aware of that risk. And then medical errors, and having committed a medical error is a risk factor for suicidal ideation. And again, another potential flag. So with all these factors together, we could predict a reasonable proportion of the risk for suicide, but certainly not in any kind of perfect way. And still many subjects in our study who didn't have these specific characteristics or symptoms or experiences and still had suicidal ideation. So there's still a lot of work to do to identify other drivers and exactly who, and maybe even more importantly, when these individuals are most at risk.
While it is well documented that physicians have a higher suicide rate than their non-physician peers, relatively little is known about suicide among medical trainees. However, it is clear that the pressures of medical education significantly increase the risk. A 2021 paper using data from Dr. Sen's intern health study revealed that 3% of interns reported suicidal ideation before beginning residency, with this figure rising to an average of 6.9% during residency. Notably, Dr. Sen and his colleagues found that approximately 16.4% of residents experienced suicidal ideation at least once during their intern year. We asked him if these findings surprised him and what's driving these numbers.
It's startling and somewhat jarring to think that 16% of residents had thoughts of suicidal ideation and thoughts of death during that year. That's a remarkably high number. And given the number of interns there are around the country and residents, that there's a lot of them who are having these thoughts. It wasn't surprising in the context of their experiences and the high rates of depression and anxiety that they have during the year. And those are generally drivers of suicidality, and suicidal ideation is a symptom, and suicide is the most tragic consequence of depression. So given that, half of interns have an episode of depression during the year, and similar numbers have anxiety symptoms or episode of anxiety, that suicide would also be at high levels is not surprising.
In the often unforgiving world of medical education, where excellence is expected and any perception of weakness is stigmatized, a culture of silence has emerged around mental health issues like depression. For many medical trainees, the pressure to succeed is immense, compounded by long hours, high stakes, and the relentless pursuit of perfection. Yet within this environment, there's a pervasive stigma surrounding depression and other mental health challenges. Trainees often feel that help seeking is tantamount to admitting weakness. The fear of being perceived as less competent or less resilient than their peers can deter even the most distressed individuals from seeking help. Instead, the expectation is to endure, to push through, and to never let personal struggles interfere with professional responsibilities. Unfortunately, this culture exacerbates the very conditions that contribute to mental health issues in the first place. When depression is hidden and untreated, it can spiral into more severe conditions, including burnout, substance use, and even suicide. The paradox is stark. Medical education is designed to produce healers, yet it often leaves little room for students and trainees to heal themselves. In the context of this paradox, Roja reflects on how the very qualities that made Jack beloved by many also made him extremely vulnerable within the rigors of medical training, ultimately exacerbating a previously well-managed history of depression.
Medical school amplify a lot of what's wrong with society, and then trap particularly vulnerable, generally fairly empathetic people who are seeking to help others in a situation where they're powerless year after year after year. And I think one thing that comes with being so warm and kind is also a degree of sensitivity that made him beautiful and really showed that he really felt feelings, but certainly a degree of sensitivity that I think ultimately could have been and should have been something that was celebrated and loved. And I think it was by so many of the people who knew him. But I think it was also something that made him particularly vulnerable.
Throughout your friendship and your developing relationship and having lived together for quite a long time, were you aware of any struggles that Jack had had historically and in medical school?
I knew that he struggled with depression from a very early age, and he shared that very candidly. I knew he was on medication for it. I knew he talked about his psychiatrist and the therapist he had seen growing up as just a really wonderful and supportive resource for him. That his parents were incredibly supportive towards him going through that. He talked about it a lot in the past tense. He also shared some of the other struggles that he had with other comorbidities that made it more difficult for him to focus or take exams and be able to have as easy of a time doing that, and never complained about it, which is, I think, something else that, looking back, I have a lot of respect and admiration for him and how he did that. There was never any bitterness or self-pity. It was just, that's what it is, and I just got to work harder and make up for it and do it, and hopefully have the opportunities in front of me to be able to. He shared candidly with a couple of people, but not widely. As our friendship, relationship at school deepened, that's when his vulnerability and sharing about how difficult periods of depression had been for him, how early it had shown up in his life, how much he felt like he really needed the SSRIs that he was taking. And it was really disarming how vulnerable he could be.
You said disarming, and I want to dig a little bit deeper into that because I find it an intriguing way to speak about someone's candidness about mental health struggles. Can you describe in broad terms why medical students, in your opinion, might describe Jack's willingness to share as disarming? What about the environment would make that disarming?
I think Jack knew the environment quite well. He even found it disarming within close friendships to share because it was so authentic and personal. And he very much knew or thought that some people would see him differently if he did share that. And it was disarming because he trusted in our friendship at the time enough to share that and believed that I wouldn't. But in general, in the medical school ecosystem or even the general healthcare ecosystem, I think the reason that any vulnerability around mental health or disabilities is so disarming is because whether or not it's always intentional, I've seen many examples of people being punished for it. And punished can take on a lot of different forms. It can be the form of, in theory, we are doing this to help you and protect you, and we don't think you're able to be a doctor. So actually take a forced leave of absence, which happened to one of our other classmates. We want to make sure that you're extra protected in different ways. So we're going to put you through these mandatory psychiatrist sessions with a doctor you can't trust because they're affiliated with the medical school. We would like to see the notes from your mental health visits. Just very intrusive types of behaviors that can make it really difficult to engage with the medical system that somebody may actually need to make sure that they're well treated. It causes students not only to not share it with their classmates or their mentors, but also to not share it with their doctors. we had put together, and really by we, it was a couple of my friends and myself put together a small get-together of 10, 15 students, just close friends, out at one of Jack's favorite spots in a place that I had a lot of really great memories with him. I was sitting with a group of those same people, and for the first time, we all kind of started sharing. And I had no idea what everybody in that room had been struggling with for years. Almost every single person had some form of anxiety, depression, or serious mental illness going on. Most of those people had the first episode of medical school. And we all looked at each other, and we had spent nights out together. We had spent weekends skiing. We had spent 18-hour days in the hospital together, and we had no idea. I think 4 of my classmates in that conversation said that they had considered taking their lives at some point during medical school, which just completely shocked me. Because these were just regular, happy, seeming, really well-performing medical students, some of the most popular and well-liked people at the school.
Dr. Jessi Gold, the Chief Wellness Officer for the University of Tennessee System, Associate Professor of Psychiatry, and author of the book How Do You Feel, reflects on well-being in the context of medical education.
Do we recognize if we're unwell is mostly no. It's a cultural problem that we ignore until it's bad because we set a really high bar for what's allowed. Emotions don't fall in there. Mental health related stuff doesn't fall in there. We worry about the stigma. So there's a study of med students where they ask them, is getting help for mental health a weakness? And they'd say no, but then they say their patients would think so, their supervisors would think so, their colleagues would think so, and it would prevent them getting into residency. So at that point, it doesn't matter what you think. It matters what everyone else thinks. And that changes how you view yourself, right? Because you want to survive in that culture, and that culture says, no, you can't do that. And so you hide it. If you even get help, you don't tell anyone. So you don't actually change the narrative that a lot of us are getting help. You just keep it to yourself. But you also don't get help because you think you're not supposed to. That goes further down the line when you're in the workplace. You know, there's all this like lore that if you ask for help, someone could take your license. That's scary. You just gave up all your friends, all your money, all your time, your entire identity is in this one thing. And if you ask for help, you better be darn sure you need it because they could take your license. That's a scary thing to be told. And it's not really as true as it used to be, but that lore still exists. If you look at licensing, this has been a big movement, especially since COVID, to change something tangible. The Federation for State Medical Boards is only allowed to ask current impairment, which is not, have you ever in your entire life ever seen somebody for mental health? Like that's ridiculous. But slow and steady, that's changing, but it's not like that in every state. And I think that scares people too, because medicine's a very movable field and you want to be able to move between states and get new jobs. And if you got help at one point and you now can't work in another state because of it, that's also feels like a barrier. Yes, it's a barrier that hopefully is getting changed, but the idea that coming to me means you have to check a different box, which could affect your career and your life. Of course, you have to be really sick for that. Why would you do that at any other risk? It's impacting your work. It's impacting your home life, or you have no choice because you're not functioning. That's where we get to when we finally ask for help. And that's a really high bar.
Suicide rates among medical students and trainees are alarmingly high, with studies indicating that the prevalence of depression in this group is significantly greater than in the general population. Nearly 30% of medical students experience symptoms of depression, and up to 10% have contemplated suicide. As Dr. Sen mentioned earlier, up to 16% of residents have considered suicide during their training. These statistics are devastating, yet they only scratch the surface of the issue. Dr. Justin Bullock, a mental health advocate and author of the New England Journal of Medicine article, Suicide: Rewriting My Story, offers deeper insights into the complex and often hidden struggles faced by those in medical training.
I think something that we cannot talk about enough is suffering in silence. And suffering in silence happens for mental illness when mental illness meets stigma. The devastation of suffering in silence is so much bigger than even these statistics can capture. And there are a lot of reasons that people suffer in silence. I've suffered in silence because I knew that I was sick. I was seeing a psychiatrist and a therapist, but I was doing okay in my classes. So I told myself that I wasn't that sick. I suffered in silence because I knew that my family and my community, they believed in me. They believed that I was strong and that I was resilient. And if I asked for help or took time away, that would make me weak. To this day, even after confronting those demons and actually feeling like I've made a lot of progress, I suffer in silence now because I have personally experienced what the medical system does to people like me with mental illness. I think one of the things that has given me comfort is very deeply knowing that I'm not alone. From the first time when I was a first-year medical student and I shared with my class, and dozens of people came up to me after and shared their own experiences, to over the last 10 years, where I've literally talked with hundreds and hundreds of people, doctors, nurses, therapists, living with serious mental illness, suicidality, depression. That has helped to break my own suffering in silence. There are very few doctors who complete training without having a direct link to suicide. And when someone dies by suicide, it's not just a statistic. It sends entire shockwaves through the communities, friends, family. I remember one of my co-residents died, and we got an email a few days after sort of expressing sadness and condolences. And after the condolences, one line down, there was something that said, "Please apply for the editorial internship at a very prestigious journal." This lack of meaningful dialogue really amplifies the need for why we need to have more honest conversation about mental health. People are afraid to talk about it. People don't know what to say. And we really struggle to break the silence. Oftentimes it's because we are suffering too.
As you heard from Dr. Bullock, the statistics do not tell the full story. Indeed, it's clear that even on anonymous surveys assessing suicidal ideation, some trainees do not feel safe disclosing that they've had or are currently having these experiences. In this next segment, we return to Dr. Lisa Meeks interviewing John and Jennifer Ruddell, live in Los Angeles.
One of the reasons that we bonded over our belief that mental health is health and that we shouldn't shy away from talking about suicide. I know you've had loss recently, and we've talked a little bit about how a loss is treated or a pathology is treated by other people versus how people are receptive or respond to a mental health crisis or a loss by suicide. And that was one of the things that was so striking for me, was your dedication to this, the destigmatizing of mental health and this visioning of it as part of the spectrum of health. Do you want to share
those two experiences? And
unfortunately, I've lost 4 siblings, all at a relatively young age. And I've lost 2 brothers to heart disease. I've lost a brother and a sister to cancer, a sister within the last several months. And it's a tragedy. It's an absolute tragedy. And we rightly reflect on that. And we look at those beautiful loved ones that are lost with this respect and this just amazement at the grit and the dedication and the courage that they had to fight off that disease and to fight to live. And that is appropriate because it is a fight. Nobody wants to die. They want to get well, and it is a grueling process sometimes. It's no different for Jack. When we lost Jack to suicide, it was devastating, and we were and continue to be numb many times. It's just such a tragedy. But from the beginning, we just never even thought of not mentioning how Jack died. Mm-hmm. And we never even thought that it would be different. Mm-hmm. Jack did not want to die. Mm-hmm. Jack took such good care of himself. Mm-hmm. Jack understood the body, respected self-care, but he fought to be well. And some days it was harder than others, but he showed such courage to just continue to be well and live. And when someone loses that battle, it's just like losing the battle to cancer. It's just like my brother's losing the battle to heart disease. It's so tragic.
Jack, he fought with such courage and such grace and kindness for others. He just wanted the pain to stop.
Yeah. That's a tragedy to those who lose someone to suicide. It's a tragedy to those who aren't able to talk about it because of a stigma or some darkness. And
they feel shame.
Shame. Jack's life was brilliant. It was just, he made such an impact.
He was a gift.
And his work and the interface he had with people will continue to have an impact. And we've been told this from so many of his friends and others that he spent time with that just were inspired by Jack. And so a brilliant life with so much accomplished, and in spite of challenge, being able to be there and be that person that he was. The last thing that should happen is to have some darkness shade the end of his life, or to have some asterisks at the end of this beautiful 25, 26 years that is just not in any way reflective of who Jack was. He was brave. He fought, and we don't know, and it's hard for us to imagine the pain that he was going through at that time. And that's the tragedy of suicide, is that you don't know.
You don't know. You'll never know.
And you'll never know. And for him to fight so hard and to show such courage and ultimately lose that battle, that's not shame. We're proud. Mm-hmm. You know, Jack, he left such a wonderful example, and he lived his life with courage. And it's something that has changed our lives as a family and as parents. The loss is never going away, but we respect Jack. And even in his passing, I think there's examples that he has left us, that just the courage to to be present and the courage to continue to fight. And death by suicide, and in Jack's instance, and so many that are like Jack, is not something that should be swept under the rug. It's not something that should be spoken of in hushed tones or should, tarnish somehow the life of the individual. It's just, it's not deserved. And those individuals, just like my brothers and sisters, Jack needs to be honored, for who he was and for the fight he fought to be well.
In this episode, we explored the data and lived experiences surrounding suicide among medical trainees, with poignant reflections from John and Jennifer Ruddell on the life of Jack Ruddell, to whom this series is dedicated. Insights from experts like Dr. Christine Moutier, Dr. Srijan Sen, and Dr. Jessi Gold, along with the lived experiences of Dr. Justin Bullock and Jack's partner Roja, highlighted the risk factors and pressures that make medical trainees particularly vulnerable. We also delved into how the pervasive stigma surrounding mental health in the medical field often prevents individuals from seeking help, exacerbating their conditions. In our next episode, we'll build on this foundation by focusing exclusively on the systemic factors entrenched in medical education that contribute to the mental health crisis among students. We'll hear more from the Ruddell family, introduce Dr. David Muller, and continue our conversation with Drs. Jessi Gold and Justin Bullock. We encourage you to listen to this series in order and to share it with your colleagues. By sharing these powerful stories, we can inspire others to take action, creating a ripple effect that fosters change within medical education. Together, we can raise awareness, challenge the status quo, and contribute to a culture that prioritizes mental health and supports those who need it most.
This episode is part of a broader series dedicated to exploring the critical issue of medical training and suicide. We invite you to continue with us on this journey by tuning into the next episode. This episode was sponsored by the Docs with Disabilities Initiative. Executive producers of this episode include me, Dr. Lisa Meeks, Riley Betchkull, and John and Jennifer Ruddell, alongside our consulting psychiatrist and narrator, Dr. Joseph Murray. We encourage schools and programs to utilize content from this series for educational purposes in partnership with a mental health professional.